Hello Medicos. Good day to all of you. This is Dr. BK for you, and today I will be discussing in detail about the posterior triangle. Now, our learning objectives for today with respect to posterior triangle will be a short introduction about the neck, the boundaries of the neck, followed by that the sternocleidomastoid muscle in detail, its origin, nerve supply and actions, which we are going to see in detail, followed by that the boundaries of the actual posterior triangle, which we are going to discuss. So what are all the various walls of the posterior triangle, followed by that the subdivisions of the posterior triangles, so how it is divided into two parts. Then we will be discussing in detail about the contents of the posterior triangle, and finally we will actually touch upon the clinical aspects. So clinical aspects not only finally, in between also with respect to the appropriate structures, even there I will be discussing about the clinical aspects. Now first, coming to the introduction, mainly the neck, you look at the boundaries of the neck. So you have an upper border of the neck or the upper limit of the neck, then you have the lower limit of the neck. So the lower limit of the neck is mainly formed by the upper border of the manubrium sternum, that is the jugular notch, then followed by that the upper border of the clavicle, you are able to see here, and then you have the acromion process, and then in the midline of the neck behind you see the spine of the C7 vertebra. So a continuous round like this, bony markings. You can see the manubrium sternum upper part, the jugular notch, followed by that is the clavicle upper border, then the acromion process of scapula, and behind what you see is the C7 spine. So that forms the lower limit. So on either side, if you join, it forms a complete circle. Now coming to the upper limit of the neck, it is mainly formed by the symphysis menti, then the lower border of the body of the mandible up till the angle of the mandible. Then from the angle to the mastoid process is a imaginary line. From the angle to the mastoid process, then you continue laterally as the superior nuchal line and the external occipital protuberance. So all these things in the first introductory class to the head and neck itself, I have discussed about these bony landmarks, especially the mastoid process or the superior nuchal line and the external occipital protuberance. So that will be the upper limit of the neck. So beyond that you enter into the face. Same way here, beyond that you enter into the pectoral region, whereas deep in the neck, deeper part you go, you enter into the thorax. So this lower limit can also be considered as the root of the neck. Okay. Now coming to the, since now we have actually discussed about the boundaries of the neck, the upper limit and the lower limit, the side of the neck, so you are seeing the side view of the neck, is divided into two parts, an anterior triangle and posterior triangle, by a muscle which is disposed obliquely, and it is called as the sternocleidomastoid muscle. Okay. So now before that, the side of the neck boundaries, anteriorly it is the anterior midline. So extending from the symphysis menti to the manubrium sterni, you draw a imaginary line, that is the anterior midline, and posteriorly you have the anterior border of the trapezius muscle. Okay. So that fold which you are seeing is the anterior border of the trapezius muscle. This whole structure forms the side of the neck. So the side of the neck can be divided into anterior and posterior triangle by this muscle which is obliquely displaced, and it is actually called as the sternocleidomastoid muscle. So the side of the neck in front of the sternocleidomastoid muscle is the anterior triangle, and behind the sternocleidomastoid is the posterior triangle. So today we are mainly going to discuss about the posterior triangle of the neck. But before that, let us try to understand about the sternocleidomastoid muscle. Okay. So now going to the sternocleidomastoid muscle. So here you are able to see, you can also consider it as a key muscle which is present in a superficial plane dividing the side of the neck into anterior and the posterior triangle. This sternocleidomastoid originates by two heads. So from the sternum and also from the clavicle. Okay. So it arises from the manubrium sternum and also from the upper surface of the medial part of the clavicle. So two heads, a sternal head and a clavicular head. Now these two heads, they unite as they pass above obliquely. The clavicular fibers, you are able to see, they are almost flat as compared to the sternal fibers. The clavicular fibers, they actually pass behind the sternal fibers. Okay, so they actually pass behind the sternal fibers and then they unite and they go and get inserted into the mastoid process of the temporal bone. Then also they extend laterally. The insertion also extends laterally to the superior nuchal line. So superior nuchal line is the lateral extensions you can see on either side of the external occipital protuberance. Okay, so sternocleidomastoid inserts into the mastoid process and the superior nuchal line. So the nerve supply of this muscle is mainly by the spinal part of accessory nerve, which is the 11th cranial nerve. So the spinal part of accessory nerve or the 11th cranial nerve mainly supplies your sternocleidomastoid muscle and your trapezius muscle. Sternocleidomastoid and the trapezius muscle. These two muscles are mainly supplied by the spinal accessory nerve. Now, apart from that, there is also ventral rami of C2, C3. So I will come to this later while actually describing about the contents of the posterior triangle. So action of the sternocleidomastoid muscle, what you are looking here is actually the unilateral action. So if one side of the muscle contracts from below, if they contracts from below, it actually bends the neck to the same side and turns the chin towards the opposite side. Okay, so bending of the head towards the same side or pulling the head towards the same side, and what happens is the turns the chin towards the opposite side. So that is the unilateral action of the sternocleidomastoid. Now if both the muscles bilateral simultaneous contraction of the sternocleidomastoid of both the sides, what they will help to do is they actually bring your face forward like as if you are peeping in a crowd. So it protracts. So you just put your head forward if you want to look something. For example, in the well you want to just peep your head and look what is deep inside the well or something like that. Or when you want to raise from your pillow after you are lying down, when you want to raise from your pillow directly from the supine position. Okay, so then actually you can see the contraction of the sternocleidomastoid muscle, bilateral contraction. Now one more action the sternocleidomastoid has got when acting from above. So if it contracts from above, then it elevates actually your thorax along with the sternum. What happens? It also elevates the ribs. So thereby it is helpful in accessory respiratory muscle or mainly during inspiration. So that is one of the action of the sternocleidomastoid muscle. So unilateral action pulls the head towards the same shoulder and turns the chin towards the opposite side. Bilateral action is protracting the head, and acting from above, what happens is it is an accessory inspiratory muscle. Now, what is wry neck or torticollis? So it is also called as the wry neck. Here you are able to see shortening of the sternocleidomastoid, or the sternocleidomastoid is contracted. So naturally, in a contracted position, you can see the head is actually tilted towards the shoulder and chin turned towards the opposite side. So in this picture, you can see the chin is pointing away from the contracted muscle. So this is actually called as torticollis. Now there are different types of torticollis. Mainly one is the congenital torticollis, which occurs during birth. Okay, shortening of the muscle, or sometimes an injury at the time of birth also can take place. If the head is pulled, undue pressure is given towards the head during the labor, then naturally what happens, it might also injure this muscle. Okay, so that is congenital torticollis. Acquired torticollis is which is not congenital, but it might occur due to any other reason. Okay, due to injury or due to any diseased condition, like spasmodic torticollis. So when the muscle undergoes spasm, so intermittent, what happens is intermittent contractions of the sternocleidomastoid takes place. Sometimes it might actually resolve on its own. There are many factors which might trigger. Even cold climate can also trigger the wry neck or torticollis conditions. Okay, so that is actually the applied aspect for the sternocleidomastoid muscle, the wry neck or the congenital torticollis, which is the shortening or contraction of the sternocleidomastoid muscle. Okay, so now we have understood about the sternocleidomastoid, which actually lies at the plane of division of the side of neck into anterior and the posterior triangle. So now we will pass on to the posterior triangle as such. Behind the sternocleidomastoid, you are able to see the posterior triangle. So the anteriorly it is formed by the posterior border of sternocleidomastoid. So anteriorly it is formed by the posterior border of sternocleidomastoid. Posteriorly by the anterior border of trapezius muscle. Okay, so posteriorly by the anterior border of the trapezius muscle. Base is formed by the middle third of the clavicle. Base is mainly formed by the middle third of the clavicle. Apex is the meeting point of the anterior and the posterior border. So that is the sternocleidomastoid and the trapezius muscle. Where they meet, they form the apex of the triangle. So base, I already told you, it is the middle third of the clavicle. And the posterior triangle also has a roof and also a floor. So there are so many structures in the roof, and it is covered by a fascia. You have a deep fascia covering the roof. Same way, floor is also muscular, but again they have a fascial covering. Okay, so you have the roof is also a fascial covering. The floor is also a fascial covering. Now, what are the structures in the roof? Skin. Deep to skin, you have superficial fascia. In the superficial fascia, you come across a muscle, and that muscle you see here is the platysma. Okay, so this is the platysma. It is actually a muscle of the face, derived from the muscles of the facial expression, from the panniculus cornosus. So this muscle actually forms the anterior inferior part of the roof. Posterior superior part of the roof is not covered by the platysma muscle. So you are able to see the anterior inferior part of the roof is actually covered by the platysma muscle. This muscle is supplied by the cervical branch of facial nerve. The platysma is mainly supplied by the cervical branch of the facial nerve. The main function of this muscle is reduces the concavity of the side of the neck. When it contracts, reduces the concavity of the side of the neck. Apart from that, it also relieves the pressure on the veins deep to this muscle. So you can see when you contract the platysma muscle, what happens is the skin of the neck is raised. You can see folds raising from your skin, so which also relieves the pressure from the veins, because deep to this you have the superficial veins and they are also adhered to the fascia which is present deep to it. So that is the deep fascia of the neck. Then, so in the superficial fascia you saw the platysma, and then you see the external jugular vein. So the external jugular vein crosses obliquely the sternocleidomastoid, which is also seen on the roof. Okay, so we will see in detail about this external jugular vein, because it is a very important structure which is present superficially on the posterior triangle. Then apart from that, what else you see in the superficial fascia is the cutaneous branches of the cervical plexus, mainly C2, C3 and C4, because first cervical nerve does not give any cutaneous branches. It is called as the suboccipital nerve. Only C2, C3 and C4 gives cutaneous branches. C5 onwards, it actually takes part in the formation of the brachial plexus. From C5 to C8, it is taking part in the formation of the brachial plexus. So mainly the cutaneous innervation of the skin of the neck is mainly by supraclavicular nerve C3, C4. We are able to see these nerves, they pierce the deep fascia and they divide into medial, intermediate and lateral supraclavicular nerves. Medial one also supplies the sternoclavicular joint and the skin over the pectoral region. The intermediate one will pierce sometimes the clavicular bone and supplies the skin over the clavicle. The lateral supraclavicular nerve supplies the skin over the shoulder. Now this nerve shares its root value with the phrenic nerve, which is having the root value of C3, C4 and C5. So that is why irritation of the phrenic nerve or irritation of the diaphragm, sometimes referred pain is felt along this nerve, especially along the tip of the shoulder, where the lateral branch of the supraclavicular nerve supplies it. So that is about the supraclavicular nerves. The next nerve you see is the lesser occipital nerve. So you are able to see the lesser occipital nerve. It mainly supplies the posterior part of the scalp behind the auricle. It actually hooks around the spinal accessory nerve. So that is how you can identify the lesser occipital nerve, or vice versa, you can identify the spinal accessory nerve. Okay, lesser occipital nerve. The next nerve is the great auricular nerve. So the great auricular nerve with the root value of C2, C3, it actually accompanies the external jugular vein behind, especially the upper part of the external jugular vein is accompanied by the great auricular nerve. It divides into an anterior division and a posterior division. The anterior division supplies the skin over the angle of the mandible. Anterior division of great auricular nerve supplies the skin over the angle of the mandible, because the remaining part of the skin of the mandible is supplied by the branches of trigeminal nerve. The whole of the cutaneous innervation of the face is mainly by the branches of the trigeminal nerve, ophthalmic, maxillary and mandibular, whereas a small part over the skin, over the angle of mandible is by the great auricular nerve, anterior division. Posterior division, great auricular, again supplies the skin behind the auricle and also the scalp. The next nerve is the transverse cervical nerve. The transverse cervical nerve passes anteriorly above the sternocleidomastoid to the anterior part of the neck. Then it divides into an ascending and descending branch, and it supplies the skin of the front of the neck, that is by the transverse cervical nerve. So thereby these four nerves are cutaneous branches of the cervical plexus, mainly supply the skin of the front and sides of the neck and scalp region, part of the scalp region, and also your upper part of the pectoral region, and the lateral part of your shoulder, skin over the lateral part of your shoulder. Okay, so that is the transverse cervical nerve for you. So deep to this skin, we have seen superficial fascia, platysma has been reflected, these cutaneous nerves. Deep to this white fascia, what you see here is the investing layer of deep cervical fascia. So the deep cervical fascia in the neck has many layers. One layer which is actually forming the roof and encloses these two muscles. It splits to enclose the sternocleidomastoid muscle and the trapezius muscle, and then gets attaches. So it actually encloses two muscles. Same way it encloses two glands, parotid gland and the submandibular salivary gland. Two glands. Same way it also encloses two spaces. 2 is the, actually you have to remember, for the investing layer. The other modification of the deep cervical fascia is the prevertebral layer, which will line the muscles of the deeper plane in front of the vertebra, prevertebral muscles. That will be lined by the investing layer of deep cervical fascia. So other two modifications of deep cervical fascia are the carotid sheath and the pretracheal fascia, which we will discuss later. Now, as I told you, the superficial fascia of the posterior triangle, we have seen about the cutaneous nerves, platysma muscle, and now we will discuss about the external jugular vein, because this can be actually expected as a short note. Now, the external jugular vein is mainly formed by the posterior division of retromandibular vein and the posterior auricular vein. Okay, so mainly the posterior auricular vein and the posterior division of the retromandibular vein unite to form the external jugular vein. So these two are the formative tributaries. So they might form inside the parotid gland, and then they might come out through the apex of the parotid gland. Okay, then they will descend and obliquely cross the sternocleidomastoid. Actually, they are not obliquely crossing. Since the sternocleidomastoid is present obliquely, it appears as if they are crossing it obliquely. Okay, and then what happens is, it is superficial. At the lower part of the posterior triangle, it will pierce the deep fascia. It will pierce the deep fascia at the lower part of the triangle, and then it will terminate in the subclavian vein. So pierce the investing layer near its termination and to terminate into the subclavian vein. Okay, so it has got two pairs of valves. One is the near its termination, other one is 4 centimeters above the clavicle. Okay, but these two valves does not prevent the regurgitation of the blood. So that is the formation and termination of the external jugular vein. So here you are able to see obliquely crossing the sternocleidomastoid, and then it will pierce the deep fascia to actually enter into the or terminate into the subclavian vein. So near its termination, since it pierces the deep fascia, it is very much tightly adhered to the deep fascia, especially the lower part of the vein is actually adherent to the investing layer of deep cervical fascia. So now coming to the tributaries of the external jugular vein. So mainly, you know, these two tributaries are the formative tributaries, posterior division of the retromandibular vein and the posterior auricular vein. Okay, is the formative tributaries. Then other tributaries you can see is posterior external jugular vein. Okay, so you are able to see the posterior external jugular vein. So mainly drains blood from the posterior part of the scalp and also the posterior part of the auricle. Then you have oblique jugular vein. Apart from the posterior external jugular vein, you have the oblique jugular vein. Okay, then oblique jugular vein is a vein which connects the external jugular vein with the internal jugular vein. Okay, so what happens is the venous pressure can be maintained. So thereby what happens is there is a connection between the external and internal jugular vein, which is actually called as the oblique jugular vein. Then other tributaries near its termination or terminal tributaries, you can call it as the transverse cervical, suprascapular and anterior jugular vein. So that is the anterior jugular vein, which is actually formed by small tributaries below the chin, and it runs on either side near to the midline. Near the termination, anterior jugular vein, what happens is passes deep to the sternocleidomastoid and opens into the external jugular vein. Sometimes the anterior jugular vein will actually connect with the anterior jugular vein of the opposite side, that is called as the jugular arch. When both the anterior jugular veins are connected to each other is actually called as the jugular arch. Sometimes both veins might be absent and it might be replaced by a single vein in the center, which is called as the cervical vein, anterior cervical vein. Okay, so sometimes the external jugular vein also, rarely it might be absent. So these are the tributaries, formative tributaries. Then posterior external jugular vein, then I told you oblique jugular vein, which connects the external internal jugular vein. Terminal tributaries are the transverse cervical, suprascapular and the anterior jugular vein. Okay, so that is the anterior jugular vein for you. So what is venous air embolism? Now, since it is a superficial structure, if the vein is cut, especially in the lower part, I told you that it is adherent to the deep fascia. So if the deep fascia is not cut, then the vein will not get retracted and it will bleed profusely. One thing. Second thing, since it is not getting retracted and the lumen is open, and air embolism might enter here through the external jugular vein. From there it might travel via the subclavian vein into the SVC. It might go into the heart and it might also bring about pulmonary embolism. So that is very, very important. So to retract the vein, the deep fascia also has to be cut. Then naturally the vein gets retracted. Otherwise there is a chance of venous air embolism. Then engorgement of the vein. So that means you can see the vein is bulged out deep to the skin. It acts as a venous manometer. So what do you mean by venous manometer is, when you ask the patient to lie down in a recumbent position, you can see the venous blood level falling down when they ask to sit up. Okay, but when they are lying down, what happens is the blood level rises. Then when you ask the patient to sit up, the raised blood level, what happens is, has to come down. Due to the gravity, what happens is the blood level comes down. If it is not coming down, that means a venous engorgement is to be suspected when actually the vein gets engorged if there is an obstruction, mainly the SVC. If the SVC is obstructed due to any neoplasm or growth, or if there is a right heart failure. So the right part of your heart is not pumping the blood, so you can see dilated right atrium. So right heart failure. In these conditions, the engorgement of the vein, you can see the vein actually can be seen very thick deep to the skin. Okay, so with that we finish the structures in the roof of the posterior triangle. Now we will pass on to the floor structures. So in the floor structures, it is mainly made up of muscles. So above, below, it is actually splenius capitis, levator scapulae, then scalenus posterior and scalenus medius, or vice versa, from below you can tell upwards. Now some books, apart from the splenius capitis, they also give a muscle semispinalis capitis, but it is not always forming the floor of the triangle. Very occasionally it actually peeps into the triangle, the semispinalis capitis. Same way, only scalenus medius forms the floor of the triangle, not the scalenus anterior, because scalenus anterior is again under cover of the sternocleidomastoid muscle, so it does not form the floor of the triangle. Okay, so these are the four muscles: splenius capitis, levator scapulae, scalenus posterior, and scalenus medius. They all are again covered by a layer of fascia, which is actually the prevertebral layer of deep cervical fascia. So all these muscles are actually covered by the prevertebral layer of the deep cervical fascia. So roof, you have investing layer of deep cervical fascia. Floor muscles are covered by the prevertebral layer of the deep cervical fascia. So now coming to the subdivisions of the posterior triangle, it can be divided into a large upper part called as the occipital triangle and a small lower part which is actually called as the supraclavicular triangle. So which structure divides the triangle into two is the inferior belly of the omohyoid muscle. So the omohyoid has got a inferior belly and a superior belly. Both are connected by a intermediate tendon. So the tendon is actually, intermediate tendon is deep to the sternomastoid. Inferior belly divides into a small supraclavicular triangle and a large occipital triangle. Inferior belly arises from the upper border of the scapula near the scapular notch, suprascapular notch. Okay. Now this inferior belly is actually anchored below in its place by a fascia which is called as the omohyoid fascia. Okay, so the omohyoid fascia is believed to be the upper extension of the clavipectoral fascia. Clavipectoral fascia, which actually like a sling, it anchors the omohyoid muscle. Okay, then the investing layer actually splits here to enclose these structures, and you also see more deeper part. The floor of the supraclavicular triangle mainly will be formed by the scalenus medius muscle. Then it will be formed with the first rib, and which is actually deep to the clavicle. First rib and the first digitation of the serratus anterior, floor of this lower part. Okay, first rib and also the serratus anterior, first digitation of the serratus anterior muscle forms the floor of the supraclavicular triangle. Okay, now what are all the contents? The genuine content of the posterior triangle, because other structures what we are all seeing, the roof, so many nerves, vein we have seen. The genuine content is the spinal accessory nerve. So it emerges from the middle of the posterior border of the sternocleidomastoid. Then it runs on top of the levator scapulae muscle, which is covered by the prevertebral layer of deep cervical fascia. This nerve is actually more nearer to the roof and attached to the under or deep surface of the investing layer of the deep cervical fascia. Then it passes deep to the anterior border of the trapezius muscle and supplies that muscle. So mainly it supplies the sternocleidomastoid and the trapezius muscle. Okay, so it is present between the facial roof and the facial floor. Then, so as I told you, it is the 11th cranial nerve and supplies the sternomastoid and the trapezius muscle. Now apart from that, running parallelly along with it is the C3 and C4 nerve, third and fourth cervical nerve, which is running on parallel with the spinal accessory nerve. You see here C3, C4 nerve, but they are present in a deeper plane. Okay, so they mainly supply muscular branches to the levator scapulae and also to the trapezius muscle. Now apart from that, they are also concerned with carrying proprioceptive impulses. So what do you mean by a proprioceptive impulses is the muscle sensation. So proprioception is actually mainly muscle sensation. So that is thought to be carried by the C3 and C4 cervical nerves, ventral ram. So this part, middle of the posterior border, is actually called as the nerve point of the neck. All the nerves emerging, you are able to see the spinal accessory nerve, great auricular nerve, lesser occipital nerve, transverse cervical nerve, and supraclavicular nerve. So this is actually nerve point. You should be very careful. And the spinal accessory nerve will be hooked by the lesser occipital nerve in the posterior triangle. So other contents, supraclavicular C3, C4 nerves, which we have already discussed in the roof, the cutaneous fibers of the cutaneous branches of the cervical plexus, lesser occipital, greater auricular, transverse cervical, all these nerves we have already seen. The dorsal scapular nerve, which is actually from the brachial plexus, root of the brachial plexus. It pierces the scalenus medius muscle, passes behind and supplies the nerve to rhomboids, supplies the rhomboides major, rhomboides minor and also levator scapulae. Dorsal scapular nerve is also seen. Now, the part of the triangle above the sternocleidomastoid is actually called as the carefree triangle because not much important structures are seen here. But below the sternocleidomastoid only, you see most of the nerves, brachial plexus, great important vessels, subclavian vessels, you all come across in the lower part, which is careful triangle. Above the sternocleidomastoid, this area is actually a carefree area of the triangle. Now, occasionally what happens is the occipital artery crosses the apex of the triangle. Okay, it can be seen lodged in the mastoid groove and enters the scalp. So blood supply to the blood supply of the scalp. Okay, now next coming to the posterior triangle, the remaining contents. So supraclavicular triangle part, the lower part of the triangle, I told you floor will be formed by the first rib and the digitations of the serratus anterior muscle. Now the clavicle and the sternocleidomastoid has been removed. So you are able to see the scalene muscles. Okay, so this you are able to see the scalene muscles, scalenus anterior, scalenus medius, and then you see the scalenus posterior. So in the supraclavicular triangle, you see the trunks of brachial plexus, upper trunk, middle trunk, and lower trunk. The three trunks of the brachial plexus you are able to see. They emerge between the scalenus anterior and the scalenus medius muscle. Then you can also see the branches from the root and trunk, dorsal scapular nerve, which I have already discussed. The next is actually the other nerve is the long thoracic nerve. So these are the trunks of the brachial plexus you are able to see here between the scalenus anterior and the scalenus medius. So again, dorsal scapular nerve is not seen here, it is passing behind. Then long thoracic nerve to the serratus anterior. From the trunk, you have the nerve to subclavius. So the nerve to subclavius, and then the suprascapular nerve. So the suprascapular nerve passes through the suprascapular notch to supply the supraspinatus and the infraspinatus. So nerve to subclavius, suprascapular nerve, long thoracic nerve, and the dorsal scapular nerve. So these structures you can see in the posterior triangle, that is the supraclavicular or supraclavicular part or the lower part of the posterior triangle, lower subdivision of the posterior triangle. You can see these structures. Then as I told you, the nerve to subclavius. Then one more important structure, even though it is not seen in the posterior triangle but usually discussed, is the phrenic nerve, which is seen on top of the scalenus anterior muscle, and deep to sternocleidomastoid muscle is your phrenic nerve. Root value C3, C4, C5. So since it shares its root value with the mainly the cervical plexus, it arises with the cutaneous branches which is passing through the posterior triangle. So it is pertinent to actually discuss also the phrenic nerve or include the phrenic nerve. Then nerves, trunks of brachial plexus we have seen. Then from the branches from the root and trunks of brachial plexus. We have seen that, and the phrenic nerve also has to be discussed in the posterior triangle. Now, the blood vessels, mainly you come across the third part of subclavian artery. The subclavian artery is divided by the scalenus anterior muscle into first part medial to the muscle, second part behind the muscle, third part lateral to the muscle, which you are able to see here. In front of the subclavian artery you will see subclavian vein, but deep to the clavicle. It is hidden deep to the clavicle. Okay. Branches from the first part, you have vertebral artery, internal thoracic artery, and on the left side you also have the costocervical trunk and the thyrocervical trunk. Three branches, mainly the vertebral, internal thoracic, and the thyrocervical trunk. Okay. Costocervical trunk also from the first part on the left side, whereas from the second part on the right side. Okay, costocervical trunk. Third part mainly gives only one branch, which is called as the dorsal scapular artery. Okay, so from the third part what you see is the dorsal scapular artery. Okay, now whereas apart from that, in the posterior triangle supraclavicular part, you also see the branches of the thyrocervical trunk. So here you are able to see the branches from the thyrocervical trunk are mainly the suprascapular artery. So it goes via the suprascapular, above the suprascapular notch, and it will anastomose with the branches of third part of axillary artery, suprascapular artery. Okay. Then one more artery which is not included in the posterior triangle but is a branch of the inferior thyrocervical trunk is the inferior thyroid artery, which is going to supply the thyroid gland. So from the thyrocervical trunk you have suprascapular, then you have inferior thyroid, which is not seen in the posterior triangle. Then you also see one more branch which is actually called as the transverse cervical artery. So some books give transverse cervical artery is actually a combination of dorsal scapular and superficial cervical. Okay, dorsal scapular and superficial cervical, but some books give it as differently. Okay, so transverse cervical artery again passes deep to the trapezius muscle, especially the superficial cervical artery. Dorsal scapular artery will actually accompany the dorsal scapular nerve or the nerve to rhomboids. On the right side, second part, you are able to see the costocervical trunk. Suprascapular artery, you are able to see along with the suprascapular nerve, it goes, then it passes through the supraspinous, then spinoglenoid notch to the infraspinatus fossa, and then anastomosis with the third part of the axillary artery. So it is the anastomosis, scapular anastomosis between the first part of subclavian and third part of the axillary artery. So third part of subclavian artery you see, and also you see the branches from the first part, that is the first two branches of the thyrocervical trunk, and you also see dorsal scapular artery. Then subclavian vein you come across in front of the artery. So here you are able to see only if the clavicle is removed, you can see the subclavian vein, and what is terminating into the subclavian vein is the external jugular vein. So terminal part of external jugular vein, after piercing the deep fascia, opens into the subclavian vein. So we have seen the vascular contents also. So what else you have is the lymph nodes. So mainly posterior deep cervical nodes. So the deep cervical nodes are divided into many groups: upper deep cervical nodes, lower deep cervical nodes, and posterior deep cervical nodes. Okay, they are situated along the posterior border of sternocleidomastoid. Posterior cervical nodes are situated along the omohyoid muscle. Certain lymph nodes are situated along the external jugular vein, and you also have the supraclavicular nodes. So the posterior cervical nodes mainly they drain lymph from the upper deep cervical nodes, back of scalp, through the posterior auricular occipital nodes, from axillary nodes also. all the axillary nodes, central group, apical, they go to the supraclavicular nodes. So mainly from the axilla, posterior part of scalp and auricle and upper deep cervical nodes. From there, what happens is they actually form the jugular lymph trunk. They actually form the jugular lymph trunk. After they communicate with the antero-inferior group, they form the jugular lymph trunk that will join with the subclavian lymph trunk and drain into as thoracic duct on the left side and right lymphatic duct on the right side. Okay, so that is about the deep cervical. Some of the deep cervical nodes are seen. So you are able to see various deep cervical nodes, upper deep cervical, jugulodigastric, lower deep jugulo-omohyoid nodes. So along the internal jugular vein mainly you are able to see. So they are dispersed mainly around the veins. So enlargement of the supraclavicular nodes is mainly in carcinoma of the breast or the Hodgkin's lymphoma. So when you palpate the supraclavicular nodes, when they are actually enlarged and become stony hard, then you should suspect Hodgkin's lymphoma or carcinoma of the breast. Enlargement of left supraclavicular nodes is also called as Virchow's nodes or signaling nodes, mainly seen in carcinoma of the stomach and testes. Okay, so mainly in carcinoma of the testis, early stages of the stomach carcinoma, left supraclavicular nodes is actually a signal and it is called as Virchow's glands. So these lymph nodes can be removed mainly as they lie in a superficial plane. Okay, if you want all the cervical lymph nodes to be removed, it is called as the block dissection of the neck. Mainly in carcinoma of the breast, this is performed. So it is called as radical dissection. There are very numerous modified methods. In one case where you actually preserve the nerves and the major vessels. So other aspects which this we have already discussed in the brachial plexus injury, because the trunks are seen in the lower part of the posterior triangle, that is the supraclavicular triangle. Compression of these, injury to the upper trunk, mainly Erb's paralysis. Okay, so the arm is actually abducted. Okay, mainly what happens is the arm is actually abducted and pronated and the wrist is flexed. Then cervical rib syndrome. So in cervical rib syndrome, if the transverse process of C7 is very long, it might compress the nerves or it might compress the vessels. It might produce neural symptoms or vascular symptoms. Okay, so it might be the whole ossified transverse process, or sometimes from the transverse process to the first rib you can see a facial band, ligament like structure might compressing the brachial plexus. Then you find pain, paresthesia along the distribution of the nerves. If it is a vascular symptoms, then diminished pulsations in the limb, especially diminished pulsations in the upper limb, so arterial pulsations, or edema of the face and the upper limb if there is a venous compression. Okay, edema of face and limb if there is an involvement of the subclavian vein, it might get compressed. Okay, so these are all the clinical aspects that whenever you are going to actually drain an abscess along the posterior border of sternomastoid, when you are going to subcutaneous abscess, if you are going to drain, be careful to avoid injury to the spinal accessory nerve. Okay, so with that we have completed the this one, the posterior triangle. So